بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the last lecture in the series of vascular imaging concerning the arterial diseases, and we will talk about the lesions affecting the pulmonary artery. We are going to talk about the pulmonary artery atresia, pulmonary artery sling, idiopathic pulmonary trunk dilatation, pulmonary arterial hypertension, aneurysms, Behçet disease, Rasmussen aneurysm, intravascular metastasis, pulmonary artery encasement, Takayasu arthritis, pulmonary filling defects, embolism, and finally we will have some words about pulmonary artery sarcoma. Starting by the pulmonary artery atresia, and we know that this atresia usually affects the main pulmonary arteries, the trunk and the right and left main branches, but the intrapulmonary branches are usually developed. Now, this atresia may affect the right pulmonary artery, and usually it is not associated with any other congenital anomalies, while atresia of the left pulmonary artery may be associated with other cardiac anomalies like fallot tetralogy, for example. And this is an example where you can see that the main trunk of the pulmonary artery is atretic, while the left and right main branches are somewhat developed. Also, you can see that there are the collateral circulation developed from the aorta to supply the pulmonary arteries. These collaterals are known as the major aortopulmonary collateral arteries, which are usually referred to as MAPCAs. And these MAPCAs are frequently written in the report, standing for the collateral circulation developed from the aorta to supply the pulmonary circulation in cases of atresia of the major pulmonary arteries. Actually, this atresia has variable presentations, and this will be discussed in details in the lecture of congenital cardiac diseases. But here we are providing only examples of pulmonary artery atresia. You see here the atretic main trunk, while the left main branch and the right main branch are usually developed. Many times you can see a patent ductus arteriosus deriving the blood from the aorta to the pulmonary circulation. And this is also an example of right-sided pulmonary artery atresia with patent ductus arteriosus and a lot of MAPCAs, or a lot of collateral circulation seen within the mediastinum. And here you can see that the right pulmonary artery is atretic, while the left pulmonary artery is present. Actually, you cannot appreciate this anomaly from the plain film, but CT and CT angiography especially are of importance for the detection of these pulmonary artery anomalies. And if you look carefully, you can see that there are collaterals derived from the internal mammary artery as well as the intercostal arteries. Then we came to the pulmonary artery sling, which means that the left pulmonary artery is arising from the right pulmonary artery. And this is the trunk, and this is the right pulmonary artery, and this is the left pulmonary artery. In order to reach its usual location, it has to cross the mediastinum, usually between the trachea and the esophagus, then to reach the left side. Considering this location, the trachea and the esophagus are usually at risk of compression. And in the plain film, you cannot appreciate this anomaly, while in the barium study, any of the vascular anomalies of the mediastinum may indent the esophagus from its anterior aspect. But the best way for the detection of this sling is to have the CT of the chest with contrast administration to see the course of the left pulmonary artery between the trachea and the esophagus, as you can see here. And this is also an example of pulmonary artery sling where the left branch is crossing between the trachea and the esophagus to reach the left side. In most of the vascular rings, you may see an indentation of the anterior aspect of the esophagus, and this can be seen in many of the vascular abnormalities in the mediastinum and is not specific for the pulmonary artery sling. Now we came to the idiopathic pulmonary trunk dilatation, and from its name you got abnormal dilatation of the pulmonary artery, and the reference is usually the ascending aorta. And you compare the caliber of the pulmonary artery, which should be less than the caliber of the ascending aorta. Then in this condition, you can see that the pulmonary artery is usually larger than normal, but this appearance is not associated with symptoms. It is usually asymptomatic, and the patient had no evidence of pulmonary arterial hypertension. This is just idiopathic pulmonary trunk dilatation, and you can, of course, measure the pulmonary artery pressure through the echocardiography or the right-sided cardiac catheterization. Then we used to measure the caliber of the pulmonary artery in the section, in the axial section, which shows the trunk as well as the right and the left main branches. And we measure a distance about 3 centimeters from the pulmonary artery bifurcation. Then we have the actual diameter of the pulmonary artery, and you compare it by the diameter of the ascending aorta. Sometimes they use the diameter of the dorsal vertebra, which is present at the same level as an internal standard for measurements, but this is a simple way to reach the diagnosis. Then we came to pulmonary arterial hypertension, where the pulmonary arterial pressure is elevated. The normal pressure is less than 20 millimeter mercury, while pulmonary arterial hypertension is diagnosed when the pulmonary arterial pressure is more than 25 millimeter mercury, as measured by the right-sided cardiac catheterization. There are many causes for pulmonary arterial hypertension, including the idiopathic type and other types that are usually secondary to a pathology present in the lung or in the circulation in general. As you can see, other causes may include heart failure, left-sided heart failure, pulmonary parenchymal diseases, especially the fibrosis, and the chronic pulmonary emboli. And you remember the CTAF, which is the chronic thrombopulmonary arterial hypertension, secondary to chronic pulmonary emboli. Then in patients with pulmonary arterial hypertension, and you can see that the pulmonary artery trunk is enlarged with a diameter more than 29 millimeter. The pulmonary artery diameter divided by the diameter of the ascending aorta is more than 1. And the segmental artery to the bronchus ratio is more than 1 in at least 3 or 4 lobes. Then this is an example. You see the pulmonary artery branch and the adjacent bronchus, and you measure the diameter of the artery in relation to the bronchus. The artery is a little bit larger than the bronchus. And these are the types of pulmonary arterial hypertension, and we have the idiopathic type or the heritable type, drug-induced, and pulmonary arterial hypertension secondary to any of these causes like congenital heart disease, connective tissue disease, HIV infection, portal hypertension, schistosomiasis, pulmonary veno-occlusive disease, pulmonary capillary hemangiomatosis, and persistent pulmonary arterial hypertension in the newborn. And I discussed the last two issues in the pediatric imaging, considering the diffuse lung disease. Then pulmonary arterial hypertension secondary to left cardiac disease. And you know that the left cardiac abnormalities will be reflected on the pulmonary veins, then on the pulmonary arterial circulation, resulting in pulmonary arterial hypertension. And we used to diagnose pulmonary arterial hypertension from the chest X-ray by the presence of massive dilatation of the pulmonary trunk as well as its central branches. I'm sorry, with a relative attenuation of the peripheral arterial circulation. Then this appearance will be reflected on the pulmonary parenchyma in the form of heterogeneous appearance, which is well known in the literature as the mosaic appearance. The mosaic appearance represents the areas of ground glass opacities alternating with areas of translucencies, and they consider the areas of ground glass representing the well perfused lung, and the hypertranslucent areas are the slightly hyperperfused lung tissue. Then if you look carefully here, and you can see that the diameter of the ascending aorta is much more than the diameter of the the diameter of the pulmonary artery is larger than the adjacent ascending aorta. In this case, you can see that there is extensive calcification of the mitral valve, and this has resulted in significant dilatation of the left atrium and the elevation of the pulmonary arterial pressure, which is reflected by dilatation of the pulmonary artery in relation to the adjacent ascending aorta, as well as the presence of calcification of the pulmonary artery, which indicates a chronic elevation of the pulmonary arterial pressure. Then you remember from the lectures of diffuse lung disease that pulmonary fibrosis, idiopathic pulmonary fibrosis, or fibrosis secondary to other diseases will compromise the peripheral blood flow to the lung, and this will be reflected on the central pulmonary circulation, resulting in significant elevation of the pulmonary artery pressure with dilatation of the pulmonary artery compared to the aorta. And you remember this also, which is chronic thromboembolic pulmonary arterial hypertension, or what is known as CTAF, which is elevation of the pulmonary arterial pressure secondary to showers of pulmonary emboli at a small level, obliterating the peripheral circulation, which will be reflected on the central circulation. Then we have another type which is known as multifactorial pulmonary arterial hypertension, and there are some of the underlying causes like hematologic disorders and systemic disorders like sarcoidosis and lymphangioliomyomatosis. metabolic disorders like glycogen storage disease or thyroid pathology, and other causes as chronic renal failure or segmental pulmonary arterial hypertension. In this case, you can see the classic appearance of interstitial lung fibrosis with areas of honeycombing as well as traction bronchiectasis. And you can see that the pulmonary artery and its branches are significantly dilated compared to the adjacent aorta. In this case, with combined pulmonary fibrosis and emphysema syndrome, you can see the manifestations of fibrosis and emphysema as well in the same patient, together with the presence of a pulmonary mass in the upper lobe on the right side, representing a bronchogenic carcinoma, which is not related to this syndrome. In this syndrome, you got the classic appearance of fibrosis by the presence of honeycombing and traction bronchiectasis, and you got the appearances of emphysema in the form of paraseptal emphysematous bully as well as in centrilobular emphysematous bully as well. Then, if you look here, and you got an example of pulmonary interstitial disease, which is reflected on the pulmonary artery with abnormal dilatation of the pulmonary artery compared to the adjacent aorta. And here you can see an example with chronic thromboembolic pulmonary arterial hypertension. And this patients, you do not usually see central emboli because the emboli are usually peripheral and they are not seen on imaging. But the history is positive for pulmonary embolism, and also you see the effect of these emboli on the pulmonary artery, which is dilated, indicating the elevation of the pulmonary arterial pressure, together with the presence of multiple collateral circulation within the mediastinum to compensate for the lung perfusion. And here you got also an example of what is known as multifactorial pulmonary hypertension. And here you see the interstitial lung disease. You can appreciate the dilatation of the pulmonary artery branch compared to the adjacent bronchus. And also by the echocardiography, you can measure the diameters of the right ventricle, and you measure also the pulmonary artery pressure. And this patient is diagnosed to have scleroderma, which can of course affect the pulmonary circulation. Then there are many signs for the diagnosis of pulmonary arterial hypertension, and these signs include: number one, dilatation of the main pulmonary artery with a diameter more than 29 millimeter. And the diameter is measured at the bifurcation perpendicular to the lung axis. As I mentioned before, you measure the distance about 3 centimeters, then you cross perpendicular to the axis of the artery to measure the diameter. Then the diameter of 29 millimeter or more is positive for pulmonary arterial hypertension with 85% sensitivity and 90% specificity. Also, you can measure the segmental artery to the bronchus diameter, which is more than 1 in 3 lobes, and this is 100% specific for the diagnosis of pulmonary arterial hypertension. The ratio of the pulmonary artery diameter to the diameter of the aorta should be more than 1 to 1, and this correlates very good with the presence of elevated pulmonary arterial pressure. Then in the literature, they said that if the major branches of the pulmonary artery are also dilated, which is usually present, and this is not a good indicator for pulmonary arterial hypertension. It is the main trunk which is important for measurements. Then the bronchial artery related to the pulmonary, the dilatation of the pulmonary of the bronchial arteries, which drive the collateral circulation in cases of decreased pulmonary perfusion, is also one of the examples. Then the complications of elevated pulmonary arterial pressure usually include the development of central arterial thrombosis, like this and here, the arteriosclerotic calcification of the pulmonary arteries, and the development of dissecting aneurysms. Then in the lung, you got many abnormalities in patients with elevated pulmonary artery pressure, and the best of them is what is known as the mosaic appearance, where you got areas of ground glass alternating with areas of hypertranslucency, and sometimes you got atelectatic bands or scars, which represented the site of a previously developed lung infarction. And this is what we mean by the mosaic attenuation, where you got alternating areas of ground glass and areas of hyper translucency, and this represents the mixed oligemic and plethoric lung. The oligemic lung usually appears hypertranslucent, while the plethoric lung usually appears with ground glass veining. Also, there are cardiac and mediastinal signs for pulmonary arterial hypertension, and these include number one, enlargement and dilatation of the right-sided heart chambers, the right ventricle and the right atrium. Number two, bowing of the interventricular septum towards the left ventricle. Number three, marked or appreciable thickening of the myocardium in the right atrium. Then one of the also positive findings is the reflux of contrast material into the IVC, secondary to elevation of the pressure in the right atrium, with reversal of the blood flow through the inferior vena cava towards the liver. And this will result in simultaneous opacification of the inferior vena cava as well as the hepatic veins in the same arterial phase together, similar to the aorta. This reflux opacification of the hepatic veins can be seen in right-sided heart failure, constrictive pericarditis, pulmonary arterial hypertension, and tricuspid regurgitation, and this is known as passive hepatic condition. Then the mediastinal and cardiac it changes once more. Dilatation of the right ventricle compared to the left ventricle, bowing of the interventricular septum, thickening of the myocardium in the right ventricle, dilated right atrium, and reflux filling of the inferior vena cava and the hepatic veins. In this example, you see the measurements of the right ventricle, which is much more than the diameter of the left ventricle, with dilatation of the left atrium as well. Then in these two different cases, you can see the marked dilatation of the pulmonary artery trunk as well as its right main branch compared to the caliber of the ascending aorta. And in a different case, you can see the mosaic appearance of the ground glass areas alternating with hypertranslucent areas. Now we came to the pulmonary artery aneurysm. And aneurysm and pseudoaneurysms in general of the pulmonary artery are rare. And these aneurysms may occur in association with congenital anomalies like beta ductus arteriosus infection, like in cases of mycotic aneurysms, trauma, penetrating injuries, and vascular lesions like cystic medial fibrosis, Behçet disease, Marfan syndrome, and the Takayasu arthritis, and also in patients with chronic pulmonary arterial hypertension may develop aneurysmal formation. Then the main presenting symptom is hemoptysis, and this aneurysm requires early diagnosis since the mortality rate of ruptured pulmonary artery aneurysm is 100%. And this is an example of aneurysmal dilatation of the pulmonary artery and the follow-up after a stent or graft application with approaching the normal appearance, and the graft is also patent. Aneurysms of the pulmonary artery can be multiple, especially in patients with Behçet disease. As you can see in this case, there are three aneurysms, two on the left and one on the right, and one of the left aneurysms has mural thrombosis, as you can see here. This is best appreciated using the contrast-enhanced CT pulmonary angiography to assess the size of the aneurysm and the presence of mural thrombosis. Behçet disease is a well-known chronic inflammatory disorder. Its cause is unknown, and this disease presents usually by recurrent oral and genital ulcers with ocular abnormalities. The vascular lesions include arterial aneurysms and venous thrombosis. Aneurysms are the incidence is about 65%, while occlusion is about 35%. Pulmonary artery aneurysms are associated with poor prognosis, and about 1/3 of the cases may die within 2 years after the diagnosis. Aneurysms may be single or multiple and commonly affects the central pulmonary circulation. Many of the lesions occur in the eye associated with Behçet disease, and all these abnormalities may end with blindness. And this is a patient known to have Behçet disease, developed chest pain and dyspnea, and you got the three pulmonary aneurysms, as you can see here. And we have the reformatted images to clearly demonstrate the size of the aneurysm and its the presence of internal mural thrombose. Then if you see an aneurysm like this and you got some opacification of the pulmonary parenchyma adjacent to the aneurysm, then there are one of two possibilities for this appearance. Either this aneurysm has bled with the resultant of pulmonary parenchymal hemorrhage in the vicinity of the aneurysm, or this is a pulmonary inflammatory disease that has weakened the arterial wall, resulting in the development of an inflammatory aneurysm. Of course, the diagnosis will depend very much on the clinical picture of the patient. The usual treatment is to embolize these aneurysms, and this is the larger one and there is a smaller one. Both are occluded with steel coils. This patient had a pseudoaneurysm after right cardiac catheterization. This is the initial film. You got normal appearance, and this opacity, which is located posteriorly, as you see in the lateral view. The CT angiography confirmed that the diagnosis that this is an aneurysm with mural thrombosis, and the selective pulmonary angiogram showed the site of the aneurysm, and this is the post-embolization image. And this is also a case of multiple aneurysms or affecting the lower lobes. In the chest X-ray, you got multiple masses, and in the CT angiogram, you got the classic appearance of the aneurysm, which is a white circle inside a black circle. The white circle represents the patent lumen, and the black circle represents the thrombosed lumen. Then this is the 2D coronal reformatted image, and the 3D reformatted image classically presents the multiplicity of the aneurysms. And this patient is known to have COVID pneumonitis, developed this very small aneurysm within an area of pulmonary inflammation secondary to this viral pneumonia. And in this case, you consider that this aneurysm is the sequelae of infection. And in this example, you see that the pulmonary artery is a little bit dilated, while the right main branch is aneurysmally dilated with mural hypodensity representing the thrombus. Then we came to the infected or infectious pulmonary aneurysm, which develops in an area of inflammation, as you can see with the case of COVID infection. And also you can see it with in cases of septic emboli. And if the aneurysm has developed in an area previously infected by TB, it may be this aneurysm, which is the sequelae of tuberculosis infection, is usually referred to as Rasmussen aneurysm. And this is an inflammatory consolidation in the apical segment of the left lower lobe. And inside the inflammation, and you got this enhancing lesion, which with similar enhancement to the vessels, denoting the presence of an aneurysm. Then pulmonary angiogram showed the presence of the aneurysm, as you can see here, and this is after coiling. You got almost total obliteration of the aneurysmal lumen. Also here, you see that there is the prominence of the right hilar shadow, and on the follow-up study, you got some opacity surrounding the enlarged hilum. And the CT scan showed the presence of an aneurysm within the enlarged hilum surrounded by abnormal soft tissue. Then you remember that I have said if the soft tissue and if you discover that this soft tissue of this opacity is including a small aneurysm inside, then you know that the diagnosis is one of two. Either this opacity results from hemorrhage, bleeding from the aneurysm, or this opacity is an inflammatory lung lesion that has weakened the arterial wall, resulting in the aneurysm itself. And here you got an aneurysm with peripheral opacification or lung consolidation, which suggested the development of alveolar hemorrhage secondary to leak from the aneurysm. And this is the selective pulmonary angiography demonstrating the aneurysm and after embolization or treatment of the aneurysm. If the aneurysm is the sequelae of TB, as I have mentioned, then you consider the name Rasmussen aneurysm, which is a rare condition, an aneurysm developed within a TB lesion or TB cavity. Then you see here in this example that there is a cavity in the apical segment of the lower lobe with a very minute aneurysm related to the cavity. Another example, you see this opacity in the parahilar area, which appear to be in the middle lobe, and inside this opacity you got this very small aneurysm, and this patient is hypertensive, treated for pulmonary TB, presented with weight loss, intermittent fever, and hemoptysis. The hemoptysis is the main presenting symptom of pulmonary aneurysms. And this is the tuberculous patient with bilateral upper lobe post-tuberculous manifestations together with bronchiectatic changes. And you got an aneurysm on the right side, and this is a classic appearance of Rasmussen aneurysm. Sometimes in traumatic insults to the lung, you got pulmonary laceration, which appears as a cavity with air inside or air fluid level. Adjacent this cavity, you got a very small aneurysm, which is opacified with contrast material as similar to the opacification of the aorta. And another example of what is known as oncologic aneurysm, which means that the aneurysm is related to a tumor. And the most common is, of course, the bronchogenic carcinoma. And here you see a mass in the lung, and within the mass there is a small aneurysm from one of the branches of the pulmonary artery. This is a pseudoaneurysm that has resulted from weakening of the arterial wall by the neoplasm. And this is a very dangerous aneurysm. It may rupture at any time, and it needs, of course, intervention management. And this is the selective pulmonary angiography showing the aneurysmal cavity, and this is after coiling of the cavity itself. Now we come to the intravascular pulmonary metastasis, which means that, of course, pulmonary metastasis came through the pulmonary artery, and if they are small enough, they can pass to the periphery of the pulmonary circulation, forming the miliary shadows. And you remember that we have three types of pulmonary metastasis: the miliary metastasis, the regular metastasis, and the cannonball metastatic deposits. The main primary malignancies for pulmonary metastasis are the breast and prostate, liver and lung, kidney, and choriocarcinoma. These two lesions, myxoma of the right atrium and renal cell carcinoma, tend to embolize to the large central pulmonary branches. Large emboli will result in filling defects, simulating pulmonary embolism, while a small emboli may result in multifocal dilatation and bleeding of the vessels. Minute emboli may give the appearance of tree-on-bud appearance in the lung. And this is a good example of numerous miliary metastatic deposits scattered throughout the lung in a patient with sigmoid carcinoma. Now we come to pulmonary artery encasement, which means that the pulmonary artery or one of its branches is totally surrounded by a neoplasm or an inflammatory process, for example. The most common lesion that can produce pulmonary encasement is the bronchogenic carcinoma and the mediastinal fibrosis. Encasement is diagnosed if the lesion is surrounding the pulmonary artery at more than 180 degrees of its circumference. And this means that the lesion is unresectable because you cannot remove the lesion as well as the pulmonary artery inside the lesion. And this patient with adenocarcinoma that has been treated by irradiation, and you got the residual lesion encasing the pulmonary artery, which was stable for several follow-ups, and this diagnosed as post-treatment fibrosis encasing the pulmonary artery. And here is the big mass of lymph nodes encasing the left main pulmonary artery, which is almost thread-like in appearance. Mediastinal fibrosis is one of the lesions that are benign, and they are uncommon chronic inflammatory condition producing fibrous tissue in the mediastinum that may affect the mediastinal vessels and present either focal or diffuse type. Most of these fibrotic masses may show parenchymal areas of calcification And the most frequently mediastinal structures affected by this fibrosis are the superior vena cava and the central airways, while the pulmonary artery may be affected in about 20% of the cases. We have two types of fibrosis: the focal type, which presents as a focal mass of soft tissue density containing patchy calcification. The mass may show contrast enhancement, and if you have the PET-CT, the mass will show metabolic activity. The most common cause of this mass is TB infection and sometimes histoplasmosis. Then the pulmonary fibrosis going through the mediastinum may encase the pulmonary arteries and compromise the arterial lumen, which is reflected on the pulmonary artery in the form of increased pulmonary arterial pressure with dilatation of the pulmonary artery compared to the caliber of the aorta. Then the diffuse type is affecting all the mediastinal compartments, and in case the vessels, usually it affects predominantly the pulmonary veins, and sometimes it has a predilection to the right side, but this is not a rule. And this fibrosis occurs with other autoimmune disorders like retroperitoneal fibrosis, sclerosing thyroiditis, and certain drugs, and sometimes it may be idiopathic. And this is an example of granulomatous fibrosing mediastinitis with a mass encasing the right main bronchus and also affecting the pulmonary veins entering the left atrium. The mass shows the classic appearance with parenchymal calcifications, as you can see. And sometimes the inflammation in the mediastinum in general may heal by fibrosis, and this fibrous tissue may encase the pulmonary artery branches, resulting in significant narrowing, which will be reflected on the main pulmonary trunk in the form of a considerable dilatation. And this is also an example of diffuse type of mediastinal fibrosis encasing the vessels associated with impaired venous return, resulting in this interstitial pulmonary opacities of lymphatic configuration, which means that there is a pulmonary interstitial edema, most likely secondary to compromise of the venous return. Then you remember we have discussed Takayasu arthritis when we talked about diseases of the aorta. Takayasu may also affect the pulmonary artery and its major branches, and this may occur in about 65% of the patients. Takayasu is an inflammation of the vessel wall, resulting in compromise of the vessel lumen. The most commonly affected vessels are the aorta and its major branches, especially the subclavian arteries. The pulmonary artery may also be involved. The appearance of Takayasu will be in the form of diffuse circumferential soft tissue density, representing the inflammation of the vessel wall. This can be seen in the descending aorta and also can be seen in the right main pulmonary artery. Then wall thickening and enhancement is seen in early phases. If you inject contrast material, especially on MRI, you are able to see this enhancement. Mural enhancement is suggestive of active disease. And in chronic cases, you got mural calcification, luminal stenosis or occlusion, unilateral occlusion of the pulmonary artery, and of course, the development of collateral circulation. And this is to see that the enhancement of the vessel wall is much more evident in the MRI because of the signal void appearance of the blood in the vessel compared to the enhancement of the blood in the vessel on the CT scan, which may hinder the appreciation of enhancement of the vessel wall. In cases of long-standing disease or chronic disease, you got narrowing and even occlusion of the vessels, which is usually reflected on the pulmonary trunk. Now we came to the pulmonary artery filling defects, and the most common by far filling defect in the pulmonary artery is the pulmonary emboli, which represents about 99% of the filling defects. Other filling defects include droplets of fat in cases of fat embolism, bubbles of air, tumor emboli, foreign bodies, and pulmonary artery sarcoma, which is considered very rare. Of course, after the frequent use of automatic injectors in the CT rooms, it happens that accidental injection of air may occur if you do not ensure that you have evacuated the air from the syringe before injection, and this will result in this appearance where you got air emboli in the main pulmonary artery, and sometimes you got in the veins in the mediastinum. Fat emboli are also known, especially in cases of fractures of the long bones, and this is different from air because air will appear this in the lung window, and this fat will not appear similar to air, although in the mediastinal window they can have similar appearance. And here is the case of traumatic femoral brachiocondylic fracture, and the patient underwent surgery followed by acute dyspnea due to the presence of pulmonary fat embolism. And this is the follow-up 10 days later, showing regression of the lesions. Now we came to the major important filling defect, which represents the pulmonary emboli. And you know that we have two types of emboli, the acute and the chronic type. And the acute type, you got the thrombus, which may occlude totally the vessel or may induce partial filling defect with contrast on both sides of the embolus, which is known as the railway track sign. And sometimes you got peripheral filling defect with acute angle to the arterial wall, and you may got also the donut sign or the bolument sign. I will show it to you. They should know that pulmonary vascular obstruction of more than 60% of the circulation has a very poor prognosis. Then in this case, you got a filling defect in the pulmonary artery, and you got this also filling defect with an opacity in the related lung representing an infarction. And it is known in the literature that infarcts occur when the clots affect arteries with diameter of 3 millimeter or more or less. Then this is what is known as the bolument sign, where you got an embolus which is circumferentially surrounded by contrast material. And this is the railway track sign, where you got the embolus with contrast on both sides of the embolus itself. And embolus crossing the bifurcation of the artery affecting the left and right branches is known as saddle embolus. And here also you can see the bolument sign with contrast material surrounding the embolus, and the railway track sign on the reverse of the sign. You got contrast material going through the embolus itself. Many times you are not able to see or to diagnose pulmonary infarction from the plain film. But whenever you have the CT scan, especially the CT pulmonary angiography, then you are able to see the filling defect representing in the thrombus, and also to see the effect on the pulmonary parenchyma representing the infarcts. And this is a big embolus in the right main pulmonary branch, and the effect in the lung parenchyma representing pulmonary infarction. Then the chronic pulmonary emboli usually they are eccentric, and the patent lumen is eccentric to the occluded lumen. This indicates that the embolus is of the chronic type. Then the CT diagnostic criteria of chronic pulmonary embolism include the presence of organized thromboembolic material, the flattened filling defect forming obtuse angle with the arterial wall. I will show this to you. The presence of calcification of the thrombus, retracted thrombus, which means that this will result in eccentric location of the thrombus, abrupt cutoff or narrowing of the vessel, thrombus recanalization with contrast flowing through a thick wall artery. This is an example of calcification of the embolus, and the eccentric position of the embolus is also evident here. And this is also one of the signs you got discrepancy between the pulmonary vasculature on the right side compared to the left side. These vessels are intact and these vessels are occluded. And this is what you mean by the obtuse angle. And here you got this embolus or the thrombus, and if you look to the angle between the arterial wall and the thrombus, and you got it obtuse angle. Also, one of the manifestations of chronic pulmonary embolism is the development of pulmonary arterial hypertension with all the previously mentioned signs. Number one, dilatation of the pulmonary trunk compared to the adjacent aorta. Number two, dilatation of the right side of the heart, including the right atrium and the right ventricle and the right atrium. Number three, bowing of the interventricular septum towards the left side. Number four, thickening of the wall of the right ventricle. Number five is reflux filling of the hepatic veins as well as the IVC due to reversal of the flow secondary to increase of the pulmonary vascular pressure. Number six is the development of MAPCAS or the major aortopulmonary collateral vessels to compensate for the pulmonary perfusion. You see these emboli in the pulmonary artery, and these are the major collateral vessels. And the lung parenchyma, you have the mosaic appearance, which means that there are areas of lung perfusion alternating with areas of lung ischemia. And in the measurements of the pulmonary artery and the heart, I have mentioned before the diameter of the pulmonary artery compared to that of the aorta, the diameter of the right ventricle compared to that of the left ventricle, the marked dilatation of the right atrium. And this is a chronic pulmonary embolism showing the abrupt cut off of the vessel. You see the vessel, it is not opacified, similar to this one. This is known as abrupt cut off of the vessel, and this is also another example. You see the vessel which is not opacified with contrast material compared to the remaining vascular structures. Finally, we came to the pulmonary artery sarcoma, which is an extremely rare malignancy affecting the pulmonary arteries. Also, it affects the inferior vena cava, and it's relatively common in women compared to men. And the mean age of incidence is about 50 years. It's commonly mistaken for pulmonary embolism. You can see that there are big filling defects in the pulmonary artery, which may sometimes simulate the pulmonary arterial embolism. But there are many differences between the pulmonary embolism and the pulmonary artery sarcoma. Of course, if you have a very big embolus like this one in the pulmonary artery, this will manifest by acute severe symptoms. But patients with pulmonary artery sarcoma, the sarcoma develops over some time and the symptoms are not that acute. This is number one. Number two, pulmonary artery sarcoma will cause dilatation of the pulmonary artery, the thrombus will not. Number three, if you inject contrast material, the thrombus will not enhance while the sarcoma will enhance. Number four, if you have the PET scan, then the thrombus will not show any metabolic activity while the sarcoma will show metabolic activity. Of course, in the plain film, you are not able to see what's going on in the pulmonary circulation, but in the CT pulmonary angiography and PET CT, you see a lesion which is almost similar to the pulmonary embolism, but it shows significant metabolic activity, denoting that it is a neoplasm, not a planned thrombus. The incidence of pulmonary artery sarcoma is 0.001%, and it arises from the intima of the pulmonary artery, and these are the symptoms: dyspnea, cough, hemoptysis, weight loss, and fever. And very frequently, as I have mentioned, they are mistaken for pulmonary embolism. And I mentioned the differences between both. One of the major differences also is that the pulmonary artery sarcoma invade the adjacent mediastinal structures as well as the adjacent lung parenchyma, while the thrombus do not invade the adjacent lung parenchyma. And the PET scan will show metabolic activity of the sarcoma, but it will not show any metabolic activity in the embolus. And this patient presented by fever, cough, and dyspnea showed an opacity which is similar to pneumonic consolidation in the right lung. And this is the CT pulmonary angiography as well as the PET scan, which shows a big filling defect in the pulmonary artery on the right side, and this filling defect has shown metabolic activity, denoting its malignant nature. Also, you should remember that the pulmonary artery sarcoma will expand the artery, will invade the adjacent mediastinum, and also it will invade the adjacent lung parenchyma. And if you have the PET CT, the sarcoma will show significant metabolic activity, while the pulmonary embolism will not show any uptake. Then pulmonary artery sarcoma has tendency to invade the bronchi and the lung parenchyma. The lung may show also pulmonary metastatic deposits. Thromboembolic events may also be seen, and clinically the lesion may be similar to the pulmonary embolism. And in this patient, you can see pulmonary artery sarcoma with multiple pulmonary metastatic deposits as well as multiple brain metastatic deposits. Thank you very much. Walhamdulillahi Rabbil Alameen.